Hi, I'm Mike, and I'm joined today with Chris. And today we will be talking about examination of the wrist. So this will be taken largely, our discussion will come from an article written in 1996, Journal of Hand Therapy, entitled Wrist Examination, in which Terry Skirvin, then working in the Philadelphia Hand Center, helped us to better understand and examine the wrist by breaking it up into zones. So as an example, on the dorsal side of the wrist, she talks about radial dorsal zone, central dorsal zone, and an ulnar dorsal zone. And each of those anatomical structures that are in those respective zones and the corresponding pathology that is common in those zones. So if you're assessing the wrist, if you understand what anatomy is there, then you better understand what could be the potential problems. So we will start today by focusing on the ulnar dorsal zone or the dorsal ulnar zone in reference to one of the images we have on the screen with symptoms in time and then this graph. But before we start with, when you kind of took a look at the article and then the ulnar side of the wrist, what structures stand out to you as kind of common structures that are worth talking about on the ulnar side of the wrist?
The ulnar styloid process for one, and then we have Lister's tubercle was another, and those are the kind of the most prominent, obvious ones to find. Everything else became a little bit more, cloudy, a little bit more difficult to find.
Yeah, so the two that are often problematic are extensor carpi ulnaris. So we find that by having the wrist go into ulnar deviation and supination. So you can see it will often poke out. And so that's a provocative test in of itself. Typically we'll have the individual hold like a pen or something, and then you ask them to go in ulnar deviation and then supination. And when they do both of those and that's painful, that is a positive ECU tendonitis test. And you can see that poke up. A lot of times they won't even do it. So ECU is a common structure that is a problem on the ulnar side of the wrist, and then the triangular fibrocartilage complex, the TFCC, is another common one. And the DRUJ, the distal radial ulnar joint, which kind of straddles the central dorsal zone and then the ulnar dorsal zone. But the wrist is stabilized by the DRUJ, distal radial ulnar joint, and the TFCC, triangular fibrocartilage complex. So those two ligamentous structures, they stabilize the wrist. And that part becomes telling. If you understand what stabilizes the wrist, then you can better kind of deduce where problems lie. So if we pause here for a second and then come proximal to the shoulder. In one of our classes last week, we talked about what stabilizes the shoulder. You happen to remember?
Rotator cuff.
Rotator cuff. So muscle tendon unit. Elbow stabilized by?
Bony structure.
Bony structure. So, and wrist is stabilized by ligaments. So each of these major joints of the upper extremity is stabilized by a different type of tissue. And because it's stabilized by a different type of tissue, the approach is different. The type of injuries that you see is also different. So we're seeing rotator cuff injuries highly on the shoulder because the muscle tendon unit offers stability.
So mostly muscle tendon unit injury.
Mostly tendon. So we see a lot of fractures at the elbow and also some ligamentous structures secondary to the bone. And then the wrist, we see a lot of ligamentous problems, and then we see a lot of muscle tendon problems. But if we understand first and foremost that the wrist is stabilized by ligaments, when there's itises or tendons that cross the wrist that become inflamed, our mind immediately kind of thinks, why is that tendon overworking? It's typically overworking because of a ligamentous deficit.
A compensatory movement pattern.
Yeah. So proximally, we see that elongated the biceps. When the cuff is weak, elongated the biceps tries to act in. So ECU is one of the common structures that becomes irritated when the TFCC has some type of injury to it. So we won't go into the anatomy in great detail, but we'll introduce the fact that the TFCC is kind of like a disc. The outside of that disc is well vascularized. The inside is avascular. So if you have a peripheral tear, those do well with isometric contraction. They do well with exercise, intermittent compression. But if you have a central tear, you need to go in and have it repaired. Otherwise, it's going to be problematic. And people will describe that as a deep, deep pain. So, what is common is you'll have patients that come in and they'll have ECU tendonitis. And there's a case that I'll introduce here in a minute that will kind of highlight this. But ECU tendonitis is a common problem. Sometimes it will be diagnosed as wrist sprain. And the person doing the examination doesn't tell you whether it's radial side or ulnar side. It's from a general orthopod or from a family practitioner, and they say wrist sprain.
Does this always occur, like ECU with TFCC? Because I know in some cases, rotator cuff, you won't always have bicipital tendinopathy or irritation.
So they don't always occur together, but you think of them together and you're trying to, based on the history and the presentation, trying to ferret out if it's a traumatic accident, you could have just a TFCC tear, right?
Not enough time has passed.
Yes. If you have something that's cumulative in nature, your mind automatically thinks, okay, is there a TFCC issue and that's what's caused ECU to become irritated? Or is there a proximal issue in an individual that uses their hand a lot for ulnar deviation and supination with some power? So you kind of back out of it contextually. They can both exist together. They can also be separate. And sometimes you'll say, is it the chicken or the egg? Does the TFC cause the ECU to become problematic, or does the ECU cause the TFC to become problematic? And you can probably make a case on either or, but they're probably unique to the individual and the case. If that makes sense.
Yep.
So here's the case. So the gentleman that will be in our case, this was a real case that came into the clinic, and so he is a junior, University of Florida, and he is on the men's tennis team. So he comes in at the end of his junior year, having completed a painful season, did well but very painful, and he's very tender right over the ulnar dorsal side of his wrist. If you take him into ulnar deviation and supination, can't even get there. The thought of it just lights him up. He goes to the athletic trainer throughout the semester, and the athletic trainer is, okay, we got to find a way to work through this. So we're taping the wrist, we're doing whatever we need to do to, taking NSAIDs, anything we can do to power through it.
Yeah.
And he's able to power through it. End of the season, he's coming to consider whether to get an injection or begin therapy or something more invasive. So sees the surgeon for the first time and comes to therapy. So when we're taking history for him, and he's like, this has been going on for a couple of years, better, worse, better, worse, better, worse, up and down, up and down. No previous injections, just NSAIDs, and then tape. And I said, well, what finally brought you here? And he said, well, I went to student health care center. So kind of bypassed, or kind of with the athletic trainer's somewhat blessing, goes to the student health care center and says, just my wrist is killing me. And then they refer him over to the hand and extremity surgeons, who refer him back to therapy. So that's a little bit of his history. It's his dominant hand, so it's his racket hand, so his forehand. Weak proximally. Not weak compared to the average person, but weak compared to what is required of him for his sport. Mm-hmm. Weak core, not weak compared to the average person, but weak compared to what he's requiring of his extremity.
And that's actually a good question for you there, because I bet people would ask this. How are you determining weak core for sport, right? Is there a time, is there a movement that you're looking at specifically that's like, this is what I expect this person to be able to do in this place? So what's your mind?
Yeah, so it's it. When they have distal soft tissue injuries and they're young, you step back and you think they shouldn't have that. They should not have that. So my mind automatically goes to the connect chain. There's weakness here, and this is making up for it, or wherever the problem is. That's globally. So that doesn't directly answer the question, but you think, okay, healthy individual, young, should not be having this problem, right? Yes, they're a high-level athlete, and they're required a lot of their risk, but still should not be having this problem. So start chasing. So that's one thing to consider globally. The next thing, I think, is you place them in a position where they're compromised or they're fatigued, and you see how they respond. So for this guy, suspected that his periscapular muscles were weak and his rotator cuff was weak for what he was requiring of it. So we put him in a prone position on the mat, arm out about 120 degrees extended. So position to test low trap and or supraspinatus. Within those 20 degrees, you can change a little bit, but you really make low trap and supraspinatus vulnerable. And then I give him a body blade. He's prone, so his arm's out extended, and I ask him to oscillate the body blade. And while he's oscillating the body blade, I'm videotaping his wrist. And so when I ask him to begin his motion, what I'm hoping happens, his shirt's not on so I can see his scapula and his rotator cuff. I'm hoping to see that he initiates that movement proximally. But what do you think we saw?
Wrist moving right
Yeah,
away?
the very first thing that pops out when you ask him to do it, ECU pops out. So just like it did with me here, it pops out because he's weak proximally. So this motion to be successful with a body blade has to originate proximally, periscapular muscles and rotator cuff muscles. And so that quick and dirty assessment highlighted to me and to us that when he's compromised or when he's fatigued, ECU is gunning to help offer stabilization so that he can perform activity X. In this case, it's just the body blade. So we have this lengthy discussion about this. I'm like, okay, what likely happens is, you're warmed up, you're doing okay, and then, you're in the throes of your match, and there gets to be a point where you're giving out here, and then this is taken over. And this is just a small example of how that's happening. Now, you don't know it's happening in the match. You know after it's happened because the symptoms.
Yeah.
It's painful, but during the moment, you don't know that. So what we have to teach is we have to teach him how to recognize that in the moment, and then get him stable enough here and calm this down at the same time so it doesn't occur. So the goal of therapy becomes twofold: calm this down, make this stronger so this doesn't come back.
I think you use a really good explanation of a quick way to get to the root problem without, say, some people might go the route of, all right, how do I make this guy tired enough to show me what he's doing wrong, right? So knowing the anatomy, knowing what does what where, you were very quickly able to decipher the problem without having to spend 15 minutes getting this guy fatigued and asking him to swing a racket.
Yeah.
So cool.
Yeah.
Good thing to highlight.
Yeah. So you don't. Yeah, exactly. You don't have time for that, or you may not even fatigue them in that time.
True. Like how much does it take? It's
right.
a tough question.
But over the years, what you find is that you have to get to that point quickly, otherwise you lose their interest. Whether it's corporate executive X, athlete X, or hardworking mom, hardworking dad, time is of the essence, and so they want to get back. So you have to show them the problem in a quick way, have them understand it, and then give them a solution that's doable.
And there's nothing like feeling it in terms of a problem being a problem.
Nothing like feeling it exactly. But if we go back for a second and we go to the referral for therapy, what do you think the referral says?
Oh,
What do you think that they ordered?
probably wrist pain, and then it's just asking you like initial encounter to kind of take a look at it. My guess is they didn't really go past that wrist pain.
They didn't. So diagnosis is wrist pain, strain, and they ask us to do iontophoresis, which is a medicated patch to help mild corticosteroid dexamethasone. So there's nothing wrong with that, but that's not the problem, right? The problem, this is a symptom of a bigger problem. So we were able to, have that conversation. And the place I start with him is, because you want to build on this void, is we're doing isometrics. We're doing maximum voluntary isometric contraction where he can, and doing some percentage. At the beginning, he can barely have any load. And so what you're showing him with that, he's got the strain gauge there, can see the display. He's like, I got 2 pounds of pressure that I'm exerting here. When I'm highlighting an ulnar deviation or supination, there's nothing. So I'm like, okay, this is what we're doing. When you come into therapy, this is exactly what we're doing for your wrist. Now, when you also come in here, we're hammering your core, we're hammering periscapular and rotator cuff in a position that doesn't provide pain to the wrist. So we're strengthening here, concentrically, eccentrically, and isometrically. But here we're specifically conditioning isometrically as not to be painful.
And it helps bring down tone. And then on top of that, were you still utilizing Ionto to say, kind of accelerate your ability to reduce the symptoms really quickly, or were you hesitant of doing that, thinking that he might go back to a sport too early?
So, good point. So, Ionto, we had conversation. We elected not to do it because I think, to your point, it somewhat masks what the patient is feeling and the key to success. So if you can unravel it without that medication, and it's kind of knowing that dexamethasone and iontophoresis, it's a 6-1, half dozen the other, but it's going to be effective. So I know that this is going to be effective. So I'm going that route, and then this would be a long-term solution for him, because if we just mask the pain and he goes through exercise, we lose 4 weeks and we've got to come back to the same spot. I need that 4 weeks to have him feel what it feels like to progressively get stronger and gain confidence and proprioceptive awareness.
I like it.
So that's the mojo, right? And so conditioning here. And so some people would say, well, why are you strengthening a painful, inflamed wrist? Well, we're not concentrically strengthening it or eccentrically strengthening it. We're isometrically strengthening it with no pain.
We're just allowing blood flow, and it's not provocating.
Yes.
So we're good.
Yeah, which is going to expedite the healing. Now, he's not playing tennis at the time, so we take a break there. And then here's the other kicker. At nighttime and when he's not exercising, I put him in a Munster orthosis. Oh. So lock him down.
Yeah. So
limited rotation, flexion, extension. So we're resting except for when we're isometrically strengthening. So the strengthening is extremely selective, and then you're locking it down otherwise. So you're basically saying, we need to control all the other variables by locking it down, and then just do this. And he is one of many patients with the same diagnosis, my daughter being one of them, when she started her tennis season, where you flip that script in a matter of a couple of weeks. So you get them to now, in a couple of weeks when they do that, now they're able to exert some sizable isometric force. You've calmed the pain down, but you've just begun the journey. You don't want to give up here or even let them know that you're even close to being done, because you've got a lot of work to do. So this has to get stronger. So this is why this image is on the screen here. So if we take this gentleman's scenario, symptoms on the y-axis, time on the x-axis, and then a point of threshold is right in the middle of the screen, kind of where Megan is drawing. So this line going up and down represents the threshold, the difference between having symptoms and not having symptoms. So negative would be symptomatic, positive would be no symptoms. So when this guy came in, he's probably as high as he could possibly be on the symptom on the y-axis over here. And then as time goes on, then he's able to come down into like an area toward the middle where there's less of a threshold for a problem. So let me see if I can use this pointer here. Yeah, so he's starting high here, right? And then our job is to get him symptoms down as low as they possibly can and strength up. But after a couple of weeks, 2 or 3 weeks, his symptoms have calmed down, his pain's calmed down, and he's gaining some strength. And after about 4 weeks, he's around this threshold place where he's not having a lot of pain.
I like this representation, and I like to also add the other one of, as this goes down, there's like an adjacent graph. Would you agree that capacity kind of goes up in terms of how many things this person could do before whatever irritated them, right?
There's another... You're exactly right. So there's another graph not shown here that we show exactly that. That they're inversely proportionate. And so you're driving one down and there should be another one coming up. But what happens right here in this threshold point, as soon as people start to feel good, it can be the nature of the therapist and the present insurance environment, co-pays, etc., to say, okay, discharge. And what happens, they yo-yo back and forth until they get up here and they go back to the doctor because the problem hasn't been solved. So you haven't changed the tissue enough so that it can take on the external capacity of life. Tennis in this guy's situation, work and, the mom's situation, or aircraft mechanic, the pneumatic tool in his or her situation. So our job is to get them far enough down this curve so that when they go through daily activity, they wax and wane in an asymptomatic section, not between symptoms and no symptoms.
I think that's where a big problem for a lot of people lies.
100%. And for all, they can be good reasons too, right? Co-pays, insurance, time, distance to therapy, the fact they don't like coming into therapy, whatever it is. But it's our job to help them to see this. And when they see this, my experience has been, you're like, okay, I think you're ready. They're like, no, I'm not. No, I still feel like, and then they advocate for them coming in to see you because of the way their tissue feels.
You've created this hyper awareness now.
Yes.
Yeah. And almost this like afraid for this thing to kind of come back in a sense. Yeah.
So your goal is to make them independent of you. And in that process, I think you'll see that there's a period of dependence, not because they want to be dependent, is because they want to understand it the way that you understand it. And they want to feel it with you present so they can make better decisions. Now, once they have that, then they're like, dude, I'm good. I'm good. So if we fast forward on this guy's case, so he's in therapy in the fall, and able to compete in the spring season, has a really good season, and he's in therapy off and on for that 6-8 months because he is in that phase. He's like, I want to just check back in and make sure I'm doing things right. So he graduates, and then he sends me one of my favorite texts that I've received. He's in Las Vegas, and he's in the Darling Tennis Center there in Las Vegas.
Nice.
And he's doing well in a tournament. Makes it to the semifinals, and he texts me. He's like, Mike, I'm pulling out. I'm like, how come you're pulling out? Because he'd won, he's ready to go on to the finals. I'm pulling out because my wrist feels just a little bit like on edge, and I need to rest it so I get prepared for the upcoming weeks. Tournaments that were more important, yielded more points, more money, whatever the case was. So in his mind, the exchange wasn't worth it then, because he knew how it felt. And so in my mind, I love that because he's making these decisions, right? He's deciding, you know what, going into the tournament, I may have been here. But after 4 rounds of play, 4 rounds of 3-hour 4-hour matches, my tissue is maybe right here, back and forth. I've got to get it back down here before I can compete on a regular basis and be happy about it. And that self-regulation, I think, is really, really helpful.
That's huge. And would you say that you see that, I guess, as a success with athletes more commonly than people who are non-athletes, just because of they're more aware kind of thing? Or?
I think there's the awareness, and then there's also, like, the universe, like, he's an athlete in school, and so the money's not an issue, right? Because the school is part of his scholarship, he gets those services.
Yeah.
So now you're able to really highlight those and give them what they need. So I think both of those things are an added plus on a case like this.
Sure.
And I think that's so helpful from the therapist side, because oftentimes we don't get a chance to see that play out. And so for us to see it play out, it helps to teach us that becomes like this ideal that we're chasing, or at least, we might, schedule landmark visits in between that are less than ideal, but help to chase the same picture. So for him, it became a really helpful instrument in knowing that ECU here was the symptom of the proximal problem. There's one thing that I needed to add into that. Before he had graduated and began to compete professionally, he felt like he was sitting kind of right in here and was a little nervous that he would come back. The isometrics, as you mentioned, pump blood flow into that area to help, the nutrients, help calm down the synovial, calm down the inflammation, have the structures be strong and healthy. He had one of his surgeons recommend that he receive a PRP, a plasma-rich injection, and so he did. So in my mind, he got like this mega dose of isometrics in that plasma-rich injection.
Yeah, in a way, right?
To that area, right? And so that likely helped him to get here. So I think that was part of the equation where time, he didn't have the time for what he wanted to do to maybe get that strength back on his own. So he elected that as a healthy option, better than a cortisone option.
Yeah. Speed up the healing process, but not degrade anything in the meantime.
Yeah. So I think that's an important component here. So for individuals that have shoulder impingement, individuals that have TFCC, ECU injuries, this presents itself all the time. Soft tissue, this presents itself all the time. And helping people to understand that can be helpful. Sometimes drawing it out for them, and you ask them, hey, where are you now? And where do you want to go? And to be discharged, where do you need to be?
Yeah.
And you kind of put the ball in their court. And so you can sometimes go back to this and say, where are you? I'm like, here. But, these other factors are at play, and I'm going to have to stop therapy. Or I've got this event coming up, and I need to get to this place. How often do I need to come in to get here?
That's the question you want to hear.
Yeah. Yeah. How often do I need to come in to get here? So I think the Terry Skirvin article, Wrist Examination, is foundational to this type of thinking because it breaks the anatomical structures up into zones, and it helps you understand, okay, these are the key anatomical problems. Okay, what's their role? I step back. How do I need to manage that? Becomes a really helpful tool.
I think the stepping back is actually just as important as this article. Understanding this, and if you were to stick to this, you might only just hone in on that issue of the wrist, and you might not look right any further than that. Sometimes being too close to it's a problem as well. So Mike does a great job of noticing the issue, but also looking elsewhere. I think that's an important thing.
Yeah, you gotta kind of take them into consideration. So he's a fun case on that. And I had mentioned my daughter as being another case, tennis player as well, exact same problem, managed the exact same way, but she had to compete like him through the process. That part is the really, I think, the interesting part that's helped me the most. If it's my kid, then I can I can spend as much time on her as I possibly can, right? And soft tissue. And you learn that you're trying to get the soft tissue ready for event next, or job work the next day, or competing. And that is different than saying, I need you to stop everything and rest. For most people, that's not realistic.
Yeah.
I can't quit the job. I need to earn money. Or I'm on scholarship, and so not competing is not an option for me right now. Or, something in between. I'm a mom, and, I'm sorry, but I have to take care of my children, right?
Yeah.
And nobody else is doing those things for me. So saying that you need to rest sometimes, while that might be true and optimal, it's not a great answer. And it's kind of a non-answer to that patient. So the patient sometimes is frustrated by that. And like, everyone tells me I just need to rest, and I can't do that, and nobody's telling me what I can do in between.
Yep.
And if we can be the person that helps them to understand what they can do in between, they're going to come back and they're going to pick your brain. And you're going to provide them solutions. Okay, I'm going to wear a Munster cast if it's ulnar-sided pain. I'm going to wear that as much as I can throughout the day. I'm going to do some exercises. My kids can latch on to that, and I'm somewhat safe. Mm-hmm. I'm wearing it at night. And so you talk through what the mom has to do throughout the day, and you give her a recipe for success, something that she can do. And all of that is contextual. We've talked about in class, occupational therapy, physical therapy, and sometimes the differences, and sometimes how our approaches are different, or sometimes how occupational therapists might be saying or accused of doing physical therapy, or vice versa. That kind of whole hornet's nest. But in my mind, it breaks down to, you have a problem. What are the components of that problem? What are the components as they relate to activities of daily living? Whether that's a sport, whether that's a job, whether that's a household task, and then the anatomical components. You're breaking all these things down, and then you're trying to find something that works. And that's tough to do, but if you can find an answer to do it, then it's really rewarding. It's a career-building type of opportunity, and you make a difference in people's lives. They'll drive to see Chris because, hey, Chris gets me. That's the way they'll phrase it. Chris understands what I'm going through. He gets me. But what's not being said there is he gets you because he's taking the problem, he's breaking it down, and he's trying to find solutions that meet you where you are, but then move you.
Yep, well said.
So easier said than done. So anyway, that's kind of a blending of the symptom and time curve. And then one of our future conversations we'll pull up that graph where we compare one to the other. They're inversely proportionate. You're exactly right. All right, other concluding thoughts. Ulnar side of the wrist.
No, that was a great one. I think another good one would be talking about the difference in what you just talked about. Someone who you can control the variables versus people who you cannot control the variables, and what that looks like.
Ooh, when you cannot control the variables.
Right, when that person's life's too hectic, or they just simply can't meet the requirements that are quote unquote perfect, and how you kind of work through that.
Okay. All right, well, that concludes this segment. Thank you.